Okay, so this morning we are going to begin with a didactic presentation. I think this is our first split site presentation that we have. And the topic today is addressing the issue of undiagnosed hypertension. I happen to be very peripherally involved in a large undiagnosed hypertension project in Chicago over the last few years, which I think has become really a kind of a national model. In addition to that, Rosellen Roche is going to present as well, primarily on workplace interventions to diagnose hypertension. So we can put this into context, and then we will move on and discuss specific strategies to make sure that there are fewer undiagnosed adults with hypertension in Ohio. So we can pull up the presentation. Sorry, yes, yeah, one more. Okay, and next slide, please. So our two presenters, Rosellen is going to be presenting from Ohio University, and she's an associate professor of primary care. I think most of you know me. I'm directing the Cardi-OH portion of the Cardi-OH program, chair of the Department of Family Medicine Community Health here at CASE. My hospital role is Chief Clinician Experience and Wellbeing Officer. And most of my research is actually in children and pediatric cardiovascular risks. I do health services research in that area as well. Next slide. I don't have anything to disclose, and neither does Dr. Roche. These are our current disclosures from Drs. Brzezinski, Karukian, and Bakris, who will be joining us later on in the series. You can read those at your leisure. Oops, back one, please. And I think, Rosellen, could you start us off on the next few slides?
Sure. So can everybody hear me okay?
Yes, you sound great. Thank you.
Great, good, okay. And I apologize if I don't look like I'm looking at you. I have two screens and my camera's right there. But so when Goutham and I sort of started to put this together, we thought it'd be useful just to go over the scope of the problem in terms of hypertension and unrecognized and uncontrolled hypertension. 75 million adults in the United States have hypertension, and approximately 48 of that population has uncontrolled hypertension. But I think one of the most interesting notes is that over 30%, 36% with uncontrolled hypertension have no idea of their hypertension, and they therefore have no treatment. Next slide.
Let's go, Bob.
So one of the areas that's of interest is that where hypertension sort of pops up and where it continues to be unrecognized. And one of the tasks that we were sort of asked to look into was within the workplace populations. And I thought this was quite interesting because although we know that raised BP is associated with changes that go along with aging, vascular changes, etc., as we all know.
I'm just gonna turn off the volume on mine.
What is interesting is that as our workforce population continues to get older, we are missing unrecognized hypertension in the workplace. Next slide. So when I was looking around in some of the literature around workplace population hypertension, something that sort of popped out at me was a particular article. It's a little bit, it's from 2000, so it's a little bit older, but it was done, and a lot of actually publications are within this particular journal, the American Association of Occupational Health Nurses, which makes sense because this actually is handled on an occupational health sort of level within workplaces that monitor this for their workplace populations. But they flagged this in 2000 as a major issue of the workplace. And they had a small sample, a convenience sample of 94 volunteer employees from a corporation. But their findings revealed that they had rates of 11% and 30% of normal and hypertensive blood pressures, respectively. What was most important, that was 96% of the participants in the actual sample assumed that their blood pressures were normal. And I think this is where, you know, most people think, oh, I have no problem. The employees that did have hypertensive blood pressure reported higher levels of stress than normotensive employees. However, the population with high normal BP did report significantly higher levels of stress than normal intensive. So this idea of stress in the workplace and how it's related to BP has kind of come into the fore, and there's been a lot of discussion around this. Does stress itself create long-term BP changes, etc.? Next slide. So the literature is moving much more towards that, although hypertensive changes can happen in the workplace in the moment, if people work stressful jobs, it's more that the stress in the workplace leads to overall habits that then lead to continual high BP, which creates the changes that make trouble for us later. So, and these changes obviously are kind of the red flags that we see in clinic, things like high alcohol intake, increased tobacco use, a lack of exercise or regular exercise of some form. This is due to exhaustion or overstress, and then unhealthy nutritional habits and things like binge eating, binge drinking. These kinds of unhealthy habits can form around stressful work situations. So in a sense and in some, the evidence is pointing to there's a multitude of different factors that kind of happen related to the workplace environment that then create this onset of trajectory of hypertension, and then it goes unrecognized within the workplace. Next slide. So how can we improve workplace screening? And I found this very interesting because there's actually quite a lot of information that's coming out on this now. And the CDC had some specific recommendations, and they included periodic blood screening, blood pressure screening, and health risk assessments at the work site, again, through occupational health clinics. And lifestyle counseling, either provided at the work site or covered through employee health insurance plans. And these can be provided by healthcare or allied healthcare professionals, the occupational workplace professionals in the actual establishment. These can also, just as a side note, they can be distributed through pamphlets or online modules. They wanted to particularly draw attention to being able to reach out to different employees in different forms or means so that people can access this information, and just make them aware that if they monitor their own BP, that they may become more aware of problems that they're having. And then the other thing, and we see our chap here with his blood pressure cuff on, but is that blood pressure monitoring devices available for employees within the workplace. I thought this was an interesting point. We've all kind of walked into a CVS and seen the blood pressure monitors, and people do use them. I thought this was an interesting point, particularly in a healthcare environment where you could have blood pressure monitors available and people could just take an assessment on their own, and may be more apt to do so if it was available. Next slide. So an example of good practice. So I actually decided to dig into our own university. I'm actually on the Cleveland campus and had been on the Athens campus for 2 years. And there is a large push within Ohio University and HCOM itself for wellness and more well-being. But one thing that really stands out for Ohio University is their WellWorks program, which is in cooperation with the College of Health Sciences and Professions down on the Athens campus. I believe it was started in 2007, and it's been going for quite a long time. The cost is very low to become part of the WellWorks program as a faculty. It's $27 currently, and they're trying to move so that employees can use their flexible spending accounts to actually utilize the WellWorks program. And WellWorks covers an entire gamut of different things, but so it has a fitness center, it encourages group fitness, but currently in the past couple years, they've introduced something called HeartWorks, which is for those which are newly diagnosed with heart or lung diseases. And what they do is they work in conjunction with Ohio Health to try and monitor your progress as a faculty or staff member within the parameters that they have, blood pressure monitoring, etc., good nutrition, and good practice. And they have a lot of personal training and risk reduction programs, which they try and take a comprehensive approach to employee wellness through prevention and rehabilitation of lifestyle. So Ohio University is trying to work hard to try and reach out to its faculty and staff to encourage a more physically active lifestyle. And I thought this was a more overall and interesting approach rather than just focusing on the BP. It went down to the sort of nitty-gritty factors that constellation of factors that would lead to higher blood pressure, such as poor nutrition, lack of exercise, etc. So, and I think that's me in terms of my, does anybody have any questions about any of that so far? No? Okay, next slide.
Thank you, Roselle, and Rick, can we have the next slide? So there was a question that came up, and I think it's kind of an obvious one. It's a great question, is how do we know what the rates of undiagnosed hypertension are? And, there's many ways. I mean, the statistics on any sort of undiagnosed common cardiovascular risk generally come from NHANES, National Health Nutrition Examination Surveys, where they take a large sample, a representative sample of Americans, and do a lot of different screenings on them. And of course, they're asked in advance, do you have hypertension, diabetes, dyslipidemia? And from that, we know that new diagnoses of hypertension, for example, constitute a significant portion of those individuals. And that's how we know that there's a large number that are undiagnosed. And NHANES is not the only comprehensive survey of that type, but it's probably the most useful. So that was a great overview of workplace diagnosis and its importance. I want to talk a little bit more about the clinical setting. So it's kind of hard to believe that patients who have been established with us are still unlikely to be aware of their hypertension. And even if they are aware, their control can be inadequate. So if we look at those patients who are unaware, untreated, and have uncontrolled hypertension, most of them are actually insured. The vast majority have a usual source of care. And 60%, more than 60%, nearly 2/3 have gone to the office, have received care in two times or more in the past year. Next slide. So what is going on? Why are we not making a diagnosis of hypertension? Well, I am a pediatric hypertension researcher, and I can tell you there are specific lessons there that are applicable to adults as well. So diagnosis of hypertension in children is much more complex than in adults because the actual criteria rely upon blood pressure percentiles to a great degree. And it requires synthesis of past results. So it's a typical situation. I'm seeing a patient, let's say for asthma or heart failure or something else. That is my entire focus. You know, maybe they have something that's relatively minor. They've sprained their ankle. And I'm not paying as much attention to the blood pressure. The patient comes back and sees Rosellen a couple of weeks later to see if their ankle is better. And she's not going to pay much attention to the blood pressure either because that's not the focus of it. And in the meantime, we have these results that are being accumulated over time, and nobody has actually synthesized them definitively in order to make a diagnosis because you need more than one diagnosis. There is a phenomenon of clinical inertia. Rosellen says, oh, your blood pressure is a little high, but you're Dr. Rao's patient. Come back and see him. I see the patient back 2 weeks later and say something similar. Well, you're actually Dr. Smith's patient. I haven't seen you very much. You know, you come back and he'll address your blood pressure. I don't need to deal with it. And that, of course, is clinical inertia. That phenomenon, we know for some problems can go on for years and years and years. Without anyone making a definitive diagnosis. So it's not awareness of the blood pressure. Then there is, of course, the reluctance to make a definitive diagnosis. We see this in the pediatric world, but also in the adult world as well. I know your blood pressure is high. I recognize that it's high. But if I do make a diagnosis, I'm going to have to start to think about treatment and putting you on medication. And knowing that this is a silent killer, a lot of patients are not all that enthusiastic, of course, about having that diagnosis made. So these are some of the lessons that we have. Next slide, Rick. So if we look at, my research deals with diagnosis primarily and an approach to diagnosis known as a diagnostic path. If you look at the diagnostic path of different problems, including hypertension, in other words, what is the path to making a definitive diagnosis from first presentation of a particular problem, in this case, elevated blood pressure, to a definitive diagnosis. For hypertension, it's much, much longer than you anticipate. It's not the 2 or 3 visits that's recommended. It could be 6 months to a year before somebody is actually diagnosed, in which case they're seen in multiple different environments, and nobody has put all of this information together. Next slide. So here are some recommendations, and this is the best summary source that I have found. And many of these recommendations come from that large study by Dr. Raycott, who I think was actually originally scheduled to present this session with Dr. Roche, but was unavailable. So I'm going to be filling in. But he did a large study to identify undiagnosed hypertension on a system level using that core problem of failure to synthesize results. So these were adults who had 1 or more elevated reading of blood pressure, but nobody had made a definitive diagnosis. The patient had not been told about the possibility of hypertension, and they certainly weren't being treated. And the approach was to look into a EHR registry, which we had in Chicago, which had several million patients, looking at which of these patients had elevated blood pressure, and actually calling them in and having the AOBP device actually measure their blood pressure. This measures 6 blood pressures in 6 minutes and throws out the most extreme one and averages them, and then gives you a definitive diagnosis. So pretty labor intensive. And of course, when you call these people, some of them say, well, I knew I had high blood pressure. I just went somewhere else for my treatment, or they weren't interested in coming in. So the first lesson, of course, is you need to estimate the overall prevalence of hypertension in your practice. So most of us have quality reporting requirements, and this information should be readily available to you, especially in the Cardi-OH sites. So we know the overall adult prevalence is 29.1%. If your population is primarily African American, it should be higher, around 42%. And if you look at the subpopulation of adults over 60, it is nearly 2/3 who have hypertension. If you query your EHR, if you report quality measures, if you report a prevalence that's significantly lower than that, you probably have a problem. I mean, it's possible you have a much healthier population than the average, but given us here in Cardi-OH and the sites we're dealing with, probably not. So if you have an overall prevalence, for example, of 10% that comes out in diagnosed hypertension, that gives you a pretty good notion that something is being missed. The next step then is to query your EHR registry on a system level. There's no point in trying to be punitive. This is a quality improvement effort. So if you have 7 physicians in your practice, let's look at all of those physicians, because we all work together. We're all responsible, including other clinicians, including nurses and frontline staff, in making this diagnosis readily apparent. So you would query the EHR registry, not for the diagnosis this time, but for actual blood pressures that are above a certain threshold. Now, you can say we can use the newer thresholds that Jackson and his team have advocated, but I think even if you start with 140/90 and see how many of these people are over 140/90, have no diagnosis of hypertension, no treatment, no recorded diagnosis on a problem list or on an encounter, let's see who those folks are. And then adopt a systematic approach to assess those patients identified as potentially having hypertension. That's what Mike Raycott did in Chicago. And of course, there is a script around that. There is an outreach effort around that. And most FQHCs have someone that they can actually use to identify it. And it is, no question, labor intensive, but the overall impact on public health is quite significant. So somebody calls up these patients and has said, hey, you know, it's great to talk to you. I just want to let you know, you had a couple of blood pressure readings which were elevated over the last couple of visits, and we're concerned you may have a diagnosis of high blood pressure. Of course, you have to ask them the question, have you ever been told you have high blood pressure? And if the answer is yes, yes, and I'm going to this other place down the street and getting treated, that's fine. That's the end of that conversation. But if it's not, then we say, well, we want you to come in. We're going to check your blood pressure again, and we want you to speak to a physician. Does that sound like a reasonable strategy for you? So that's one effective way of reducing rates of undiagnosed hypertension. It is labor intensive. Another way, which we have used successfully for many pediatric and adolescent problems, is actually priming the patient. Certainly patients are highly concerned about hypertension. If you look at African American communities, diabetes is a huge concern. And a huge motivator to change behavior and to seek treatment, because there are very few families who are not touched by it. Similar with hypertension, the most effective intervention, and I've said this many times, that I've ever developed, of all the clinical decision support tools and lectures and guidelines and papers that I've written on pediatric hypertension, the most successful intervention was simply a sign that said, ask your doctor about your child's blood pressure, put in the waiting room. Boy, is that powerful. The parent comes in with their kid and says, hey, I just saw that sign, so how's my son's blood pressure? And of course, the doctor can say, oh, yeah, their blood, oh, yeah, I've got to, I didn't think about that, I've got to look at it. And then, of course, that motivates some change. Now, it's not going to be the ultimate solution, but you can prime patients. So in the EPIC EHR, there's an opportunity on the AVS, the after visit summary, to adjust it so that if the person's blood pressure is high, they get that report. And by the way, your blood pressure is high. And that's printed out to them and given to them by the checkout person. And of course, they might come back right away and say, hey, wait a second, my blood pressure is high and nobody talked to me about it. Or it says I should make a follow-up appointment. So those are some of the recommendations. But we are still at the very basics. So estimating the prevalence, and secondly, the querying of an EHR level registry. Okay, so I'm going to go through some of these comments that are flowing in. We already addressed the one about, I think, lack of awareness. We can also use our EHRs set up to alert us to know if somebody might have undiagnosed hypertension, so we can act at point of care. Absolutely. When we see the patient, it requires an EHR that allows us to program that appropriately. That's a great suggestion by Dr. Boland. I don't want to get into a lot of the concerns about EHR alerts and alert fatigue and stuff. Fortunately, at Metro Health, Dr. Kalber has a lot of knowledge about that, but that is something that does prime people as well. Alerts can be helpful in some circumstances. Our second annual statewide cardio conference, Getting to the Heart of the Matter, and we'll actually have Dr. Brewer, who will be speaking about inspiring and empowering communities to improve cardiovascular health. Obviously a very relevant topic, and she's a leading expert in this area as well. So please spread the word. We would love to have you, and if there are any questions, you can email us or email Shannon at any point. Next slide. The other thing, the reminders that we send out every week, there is a post-clinic survey that you'll be getting very, very soon. Please complete this survey as soon as possible so the details of this session are fresh in your mind. We are accredited for continuing medical education credit. So today's session is worth one hour, so one category 1 credit as well. Next slide. And the last reminder I have is our next ECHO Clinic, which will be on the 28th at 8 a.m. promptly. And this is going to be led by Dr. Sherry Boland from Metro Health. And she's going to discuss team-based approaches to hypertension management, which of course is highly relevant and is probably the direction in which most of us, if we're not already there, should be moving in the next few years or so. So thanks everyone. We are right on time, and we'll see you all next week. Thanks for joining.